I run into discussions with Bimler in Bicuspid, and I began to talk about long, narrow faces and short, square faces. And he began to throw all these prosopic things on me and talking about cephalic indices. So one day, just to communicate with myself, in taking from the long, narrow head, let's call the long, narrow face dolichofacial. Now the next thing then was mesofacial, those in the middle, and brachyfacial, for those who were short. So that caught on in the profession. A lot of people wonder where it came from in the literature, but I began to teach it and call it that. Now there's two types of face. What we do is to take the height from nasion to menton. And we can find menton or nasion in the frontal by knowing that it's on a plane with the zygomatical frontal sutures. So right here, in line with these two sutures, is going to be nasion. We measure the mandible at a G point. Now what's having that? We can take the width times 100 divided by the height, and that will give us a facial mandibular index. Now here's the skull up there labeled Adam. The skull bulcus is up at Troon. Both of them are class 1s. This one, however, is dolichofacial, this is brachyfacial. Mesofacial is in a range of 75 to 80. Anything that's less than 74 is dolichofacial. Anything more than that is brachyfacial. This one here is 95, this one here is 67. With one number, I could then classify the face in the front. Now these two cases have a cephalic index, maximum breadth. This one's 83, that one's 74. This is the brachyfacial also. This is the dolichocephalic and dolichofacial also. We still use the facial axis, the measurement of convexity, the mandibular plane, the angle of the hard palate, the lower incisor to APO, the upper molar to PTV, the lower lip to the aesthetic line. That hasn't been changed. We still use the oral Gnomon. We started out with 47 degrees. A lot of people begin to question the 47. We found with this present study that in most patients it was 46.6. 45 was a nice division of 180 degrees, so didn't make much difference. But 46 is what it is now. Now a study was done by Cornforth some years ago, supervised by Schulhoff, who was at that time the head of Rocky Mountain data system. And what he did was to try to do a study on 104 of my treated cases, an average 7 years after treatment. And he made the following findings. What he was trying to do was to determine those patients that closed up after orthodontic treatments had been done, and those that had opened up after orthodontic treatment. So there's 4 behaviors that need to be analyzed. Now, in looking for factors that would help determine what was going to do what, and he found a very small correlation. One day I went back and reviewed. It bothered me in the first place that it wasn't positive enough to be a good predictor. I had to struggle myself to find the differences between the samples. There were too many other variables for that to be a single predictor of what the mandible was going to do in long range. Meanwhile, I had long since been impressed with the basion-nasion corpus axis angle as one that was fairly uniform in growth. That in some individuals it was absolutely the same. we find now that with the closure of the facial axis, it's going to close a little bit also. The vertical growth of the ramus
レーマスの成長的な
contributes to the arc and the
その
forward position of the chin.
成長というの
If the condyle doesn't grow vertically,
で垂直的にコンダルが成
then
長
this
しない
continues to
と
go
いうんだ
down
ったら
like so.
だんだん
The
下がる
angle between basion, nasion, and the corpus axis
BA とコーパスアクシスとのなす角度
is sort of an expression of the health of a condyle in the vertical direction. I remember that in the Caucasian face, at least, at age 8, it's 31 millimeters. Now, the reason that I think that this might be better than Porion, although if you can't see the condyle, certainly use Porion. The reason for that
でなぜかというと
is that a lot of people might take the circle and pick this point, that point, or they could miss Porion horizontally a millimeter.
で水平的に見たポリオは1ミリぐらい
But if you
ずれ
bisect
て
the
書い
two
てしまうと
condyle
思います
heads, and you can see them, if you look real carefully, you can see those two condyles. So I think that you have a terminal line that would be a lot more
ですからその最
exact.
終
So that's the one thing that's missing in our summary analysis that maybe should be in.
でこれ
The first thing we do is to do a forecast and grow the mandible naturally. We think that there's just a little bit of difference in the size of the mandible and the corpus axis with treatment. Whether it's statistically significant, we'll have to wait for the processing to be done.
でその
But the mean figures show that there is a little bit increase in the corpus axis, in between a millimeter and a millimeter and a half.
まあそれ
So
1
the prognosis of space
です
is
から
favored by treatment. So we can add just a little bit on the basis of present evidence. Change the odds about 10%. if we have. Now that third molar, as I showed you in the scales here, is about 10 millimeters wide. So every millimeter is about 10% of the space for that tooth.
10% に相当する
Its coming in is a function of the space available. It might be impacted because it gets caught horizontally. So that's an ectopic eruption.
でこれは
But it would still have enough space. If you wanted to, you could probably save it if you wanted to go to the effort. So we see patients still with impactions with adequate space.
で
But the one thing you can be sure of,
だけど
if there's a lack of space,
もし
it's not going to make it.
あそれは
Even if it does come in and become a distal impaction,
で
it may be buried in the retromolar trigone. It may not be functional with the upper molar. Now, in the adult mandible then, that you've predicted, just like we've shown you now, time and time again here, take the lower incisor straight and the lower molar straight up, perpendicular with the original corpus axis.
元の
Draw it in and measure it to the new xi point. It's
それ
one way.
と在点
The mean figure is 35 millimeters. Since the second molar is 10 millimeters wide,
第二大臼歯の幅が10ミリ
if
で
you
すから
measure from the second molar, then it is 25 millimeters. Now we found, just by chance,
それからこれ
that
ま
when
で
it was 25 millimeters, we had 50% of the molars coming in. We also found
でそういうことは分かり
that
ます
with the external oblique ridge,
でさらにも
if we take a point on that ridge
で
at the occlusal plane,
それをその交互平面と合わせて引いてみると
on the plane of the second and third molars where they would be, that could be a 50% or 5 millimeter space there
でそれが滋賀の
from the
50%
second molar.
ということになり
And
ます
that's 50% of the space that you need.
Yeah.
And we found again 50% of the cases erupted the teeth with 50% of space
それで
available.
私ども
Now give yourself an extra millimeter or an extra 10%. In other words, when I get anything 40% or less,
ということは
and I don't have very severe caries where I'm in danger of losing the second molar or the third molar
40第二大
or
臼
the
歯
first molar, if I want to upright the lower denture and hold it there, and I have to bring the lower incisor upright and back a little, and I see that the second molar is tipped and in danger of being impacted,
そして
then I'm going to germinate that molar.
そ
All
し
right.
て
Now that's the story on the third molar.
でまあ
If it is going to be crowded, then it frees up the second molar. And the same applies to a child that's 12. If you're going forward even at the 12-year-old, and you're going to try to get those teeth in there, and that second molar is still down and having a trouble coming in, it's no longer a nucleation, it's a coronal extraction. But with high speed,
get
a hold of the tooth with a hemostat. Be careful that you don't blow air into the soft tissue, because a child got an air embolus and died. Somebody was trying to do an extraction in it. And had a problem, and the child died. So, I mean, surgery's surgery. So be careful. Take a piece of it, take a rongeur in there and turn it, break it up, suck it out. So these are techniques that you can take the whole crown out, but surgeons don't like it because it starts turning around in the crypt. And I said, well, if you don't want to take them out, let me do it, because I've done enough of them. So I think it's easier to take a crown out than it is to dig all the way down, take a big bone plate off, and then have to get the third molars out that way. Now with treatment, let's say the molar is going to be moved forward 2 millimeters. That increases the odds 20%. On that third molar. 2 more millimeters from what you had before. Now if you extract and you blow the anchorage, that could be as many as 4 more millimeters. So if you had 5 to begin with, now you got 9. I mean, that's money in the bank to keep the third molar. Don't but let's say I'm going to, with treatment, hold the molar back 1 millimeter, and the prognosis is only 3 to begin with. Now it's 2. What are you dealing with? Now which would you rather do? Take a second molar out or the third molar out? From a management standpoint, what's going to be the best? Taking the third molar out is better any day. I took a second molar out when it was impacted in a little girl one time, and I waited 6 years for the third molar to come out, and it never did get closer to the first molar than 2 millimeters. So the third molar coming in is not guaranteed by the removal of the second molar. In addition to that, you have to go back and retreat the occlusion back there to have a nice curve and have that all fit and occlude the way it should. Or you simply accept something that's inferior in that molar occlusion. So if I've got to take out something posteriorly, definitely, I would take out the third molar, except in those cases where the third molar is very good, and in those cases, even as adulthood, the third molar is impacted and the second molar is soft tissue impacted. I took second molars out in Bunny when I treated her. I took second molars out in my son. A huge third molar down there, and it had eroded all the posterior margin of the root of the second molar. So he had to live with a pocket the rest of his life if I took out the third molar. So it was difficult, but I took second molar out, packed with gutta percha under the third molar.
で、7番をどけて、それで8番にガットパーチャーをつけて少しずつ出します。
Maybe you'll see him over there. He's 35 now. Now I also believe this. There's entirely too much evidence now that the third molar can be a factor in the crowding of the lower arch. There's a lot of studies been done on this. I had a patient. I've had 2 patients in my career that I had a 4 to 4 on retainer. The third molar started to come in, and it apparently had a lot of force. The occlusion was held intact anteriorly. The second bicuspid slipped lingually on the left side. Why both of these were on the left side, I don't know. So I went in and had the third molar taken out. One of them healed spontaneously. It kind of corrected itself. The other one I went in and did a little more treatment, pushed the molar back and got them.
So
this time it stayed. Getting the third molar out helped. Now, if there is a force of eruption, we can calculate with the 0.2 of a gram per square millimeter of unfaced surface. That's 1/5 the force that it takes to intrude a tooth. Remember Mura's experiment, the incisor of the rabbit. 3 grams slowed it down, 5 grams stopped it, 7 grams intruded it. This shows then that there is a force of eruption. There has to be. Or else how could teeth get in if they didn't have a force? Now if that's the case, why would the third molar not have a force of eruption? Now if it's coming straight down the arch, it could be as much as 25 grams. Now whether or not that's enough to jam a whole arch or not, I don't know. But even if it wasn't pushing forward, it would be a stop or a barrier for any adjustment of the arch that would want to go posteriorly, such as a tight lip. It would be a barrier against adjustments in the arch elsewhere. All I can say is the average orthodontist is not going to sit around and wait if a third molar has an impaction to wait and see if the arch will break. Tweed used to show cases when he finished with the lower molar tipped back, the upper molar tipped back in here. And as growth would take place, they would come back down into a good position, and also as the space closed. And he felt then as they tipped them back, as they tipped forward, then they would close up the space for him. He'd have occlusion that way. He did that for years. That was the molars. The premolars can drift distally. The interesting thing to me is that a lot of times you'll see patients relapse anteriorly, and the space for an extracted first bicuspid will still be there. Crowding here, space here. So there's something about the drift of teeth and the tendencies for them to go. There's a real memory there. It doesn't bother me to tip a molar a little bit. I think it is risky to tip them back too much. I like to keep the upper molar upright, so that when it settles in, it's got that lock. That distal buccal cusp should be seated, so that's locked the mandible. That stabilizes the mandible. That's what I like to see. I think then that I'm stable when that happens. If I've got the upper molar too much this way, it comes in, it's going to break that buccal occlusion a little bit. Unless I'm lucky enough to have a real brachyfacial growth pattern. So I think that tipping them back that much, leaving them there is playing with the odds too much. Okay?
There's one more.
All right.
Any comments to make about Herbst?
Herbst?
Yes. If you have any, please let us know.
Right here, I have 2 samples of Herbst cases. It's the greatest mover of the lower arch I've ever seen. You want to move the lower incisors downward and forward, it'll really do it. We haven't seen a long-term sample of Herbst cases. It's very dramatic, very rapid, but it also relapsed very rapidly. It's a lot of trouble. Now I've used it, I got into it 2 or 3 years ago, wanted to experiment with it, and so I put it on several patients. I saw some remodeling on the posterior margin of the condyle, but like any activation of the mandible, when it's released and the genetic pattern starts to come back, same old story. You have to hang in there and keep treating it, keep treating it, keep treating it until it gets stabilized again. You will see a case treated in a mixed dentition, for instance, that is brachyfacial with a retruded lower denture. And you throw vigorous elastics on it, hoping that you could slip anchorage in the lower arch. And you do. And with the vigorous elastics, the mandible goes this way. Now, when you take it out, the mandible goes this way,
で
and
そ
the
のゴム
denture
外
goes
したら
back.
元に戻ってしまうんです。
So that's the story there. Now, I'm going to be talking a little bit about a procedure that I use for these very, very tight lower lips.
試してみたいと
I
思い
don't know
ま
how common they are, but he's got one.
す。で
You
先
see
生
this
そうです
crease right
ね。
here in his lower lip?
下唇の下にそのくぼみができていますが、
See it right there?
ここ。
His lower lip is very tight,
で
right
すから先
through
生の
here.
下唇って随分タイトだと思うんです。
He's got a sublabial furrow.
サ
Right
ブ
here.
ラビアルファー
How about you?
お隣はいかがで
You
すか。
got one? No, him back there.
で後ろの先生。
He's got a tight lower lip.
先生もその下唇が
Pick this up and look at it. And if you got crowding in the lower arch and the face will take a little forward movement of the lower incisors, why take out 4 teeth for a lip condition?
抜歯す
Treat
る
the
と
cause.
いうことはダメだと思うんですね。もしかしたら口唇があまりにも近くて押しているのに、
So I got a
唇の問題を歯で
surgical procedure
解決するのはダメであり
that
ます。
I've done 110 times. I've sent the paper in 4 times and they rejected it 4 times. So they can have it now. Okay, I'll put it in a surgical journal.
でこれ